Assalamu alaikum wa rahmatullahi wa barakatuh. It is really my pleasure and privilege to be with you today. I would like to start by thanking Professor Yasser Amir for the opportunity to speak to you today. I'm going to speak to you about some of my own life lessons, having been a graduate of the Faculty of Medicine at Al-Azhar University. And I want to talk to you about how the safety of bariatric surgery has reached where it is today and shed some light about our methods in teaching based on the deliberate practice methodology. So without further ado, I'll get started. This is my disclosure slide. It shows financial disclosure at the type, but also it shows what procedures I do. Roux-en-Y gastric bypass is the most common procedure I do. Also do sleeve gastrectomy and duodenal switch. My practice is primarily bariatric surgery. So I wanted to talk to you first about the importance of saying yes to opportunities when they come your way. I want to show you how the Gulf Obesity Surgery Society, the Pan-Arab Society for Metabolic and Bariatric Surgery, and the IFSO Middle East North Africa chapter were started, because this is important history and it shows the importance of collaboration in our field. Then I want to briefly talk to you about the safety and efficacy of metabolic and bariatric surgery and how especially the safety improved. I don't think there's time to talk about efficacy today. And then finally, I want to talk to you about something that is near and dear to my heart, which is deliberate practice in bariatric surgery training. So I want to start first by telling you a story. In 2004, I was a fellow at Washington University in St. Louis. And one of my mentors, Mike Brunt, asked me to write a manuscript for him. So I did and expected to get a Word document back with some track changes and some redlinings on it. And maybe I expected even a printed paper with some marking with a pen. This is what we did at the time. Instead, he actually sent me a one-line email and he asked me to take a medical research writing course at the medical school. And to be very frank, initially I was quite offended, but then after I thought about it, I decided to take the class. The class was 8 weeks, the first phase, and I decided to take the advanced course for another 8 weeks. And this book was the course material for the class, The Essentials of Writing Biomedical Research Papers by Mimi Ziegler. And that course proved to be the most important thing I learned about writing papers. But it came to me through advice that initially I did not like. So remember all the time that not all advice that's given to you, if you don't like it, is bad. I want to tell you also another story about sponsorship. This is Carl Miller. He is a past president of IFSO. And in 2013, I was attending my second IFSO meeting, the IFSO meeting in Istanbul, Turkey. And I was standing in the hallway and Carl Miller comes to me and he says, "Would you want to join us in the communication committee?" And I said, "Sure, I'll join you." The next thing, I was the chair of that committee, went on to establish the IFSO Virtual Academy with the help of many people, established the IFSO app that you can get now with the help of many people, and later received 3 presidential medals at IFSO, and I'm currently the treasurer and secretary of IFSO. All started by that quick conversation in the hallway with someone I barely knew and saying yes. In 2009, I moved from Fresno, California to Sheikh Khalifa Medical City in Abu Dhabi. And at the time, our chair of surgery, 1 month after I arrived, Michel Boussier, asked me if I would be interested in becoming the surgeon champion for a new program the hospital wanted to get. I did not know what the program really was and did not have experience in it. And the program was the American College of Surgeons National Surgical Quality Improvement Program. That turned out to be a major milestone in my career and helped me learn a lot about surgical quality. And I helped lead the program. We were the first program in the Gulf region, the second outside of North America. And we moved on to develop also a bariatric program. And when I went to Abu Dhabi, with the help of Dr. Muhammad Haddad, we established a bariatric program. And this is our team initially, and our team got bigger, had more people, and it was mostly based on collaboration and mutual respect and helping each other. And our program became the first metabolic and bariatric surgery accreditation quality improvement program outside of North America in 2017. And we're able to publish our results and compare it to the US. And at the time, it meant that we would be able to get a report every 6 months that compares us to US hospitals. It all starts by collaboration, saying yes, and being willing to help. So the journey of quality that started by Michel Boussier asking me went to, from July of 2009, the hospital acquiring NISQIP, to us becoming the first pediatric NISQIP hospital and the first bariatric MBS-equipped hospital. The second thing I wanted to talk to you about is how GOS, PS, MBS, and the IFSO-MENA chapter were started. And there are two important differentiations between the crab mentality, and I'll let you look that up if you don't know it, and the collaborative mentality. And one of the things I'm going to show you of how this was developed was mostly based on collaboration. In the picture, you see the members of our first team that used to put symposia for obesity. And this picture was taken from the third symposium that was done in 2011. And the team was a cardiologist, a pediatric gastroenterologist, an endocrinologist, another cardiologist, an anesthesiologist, psychologist, 2 surgeons, an obesity medicine physician, a dietitian, and a coordinator. And this team, established at an early time, in Abu Dhabi, an annual symposium for obesity and digestive disease. Then we started putting courses at the hospital and inviting people to come. And through these courses, I met one of my best friends today, Dr. Haytham Fawal, in Lebanon, and the importance of, collaboration and working together is knowing people. And through these courses, I got to know Professor Phil Shower very well, met my partner, Dr. Al-Nazir Salem, and many other people. And we used to, do live surgery, transmit it into a conference room. And that's how things started initially. Then we started adding animal labs to these courses, and we would do them at the J&J facility in Sharjah. Continued, doing the courses, and for the first time now inviting in the fourth course, leaders from the region, like Professor Fahim Bashouni, you can see here, and Professor Aid Al-Qahtani. Then, at the time, there was no Zoom really, but we had a very primitive structure to be able to do teleconferences. And these were the hospitals that had facilities to allow them to do teleconferencing. American University of Beirut, Jordan Hospital, Al-Maqasid Hospital in Lebanon, Al-Noor Hospital, Tawam Hospital, King Faisal Specialist Hospital, King Abdullah Medical City, IMC in Jeddah, Hamad, our hospital, and King Saud University. And initially, things started by us meeting once a month for an hour to discuss cases. And this became very popular. People liked it, and people had to come from different places in the city to come attend with us, because not every place had facilities and there was no Zoom. You could not do this on your phone at the time. But then this developed with the help of Dr. Sultan Al-Timyat into the first time the Saudi Society put their annual meeting, their first annual meeting in Dubai. Next month or in February, next month, yeah, I'm going to their 8th meeting. It started in this meeting in 2013 in Dubai. And from this meeting, actually, the Gulf Obesity Surgery Society was put together, and we held our first meeting in Kuwait. And Sultan al-Sabah was instrumental in putting this meeting together. And you can see many familiar faces to you from the Gulf region and internationally at the time. And we did this mostly through WhatsApp and Facebook and Telegram programs. Then we established programs in the UAE, and you can see in the picture, Allah yarhamu, the late Fawaz Turab, one of the key figures in starting these things in the UAE. Then we established the Pan-Arab Society for Metabolic and Bariatric Surgery, and I'm sure you see familiar faces, Dr. Osama Taha, Dr. Fahim Basyouni. And then from there, much more collaboration with the Egyptian Society for Bariatric Surgery and the Egyptian Society for Laparoscopic Surgery. And this led to the Pan-Arab Society for Metabolic and Bariatric Surgery, and this is the first executive board. And this led eventually to the IFSO Middle East North Africa chapter. And this led to actually the region being able to host the first IFSO World Congress in 2018, and the chapter being the 5th chapter in IFSO. Started all through collaboration and working together. Now let me tell you a little bit about the story of safety of bariatric surgery. Bariatric surgery started in the 50s by open jejunal bypass, a procedure that had 10% mortality. And through the development of Ed Mason, first open gastric bypass, then open vertical ganted gastroplasty. The late Nicolas Scopinaro developed open biliopancreatic diversion. Hess developed the open duodenal switch. Michel Garnier, open sleeve gastrectomy. Walter Porres discovered the first time that diabetes could improve with gastric bypass. And until this time, the mortality of open gastric bypass was 4%. Then Alan Woodgrove developed laparoscopic gastric bypass. Michel Garnier, again, laparoscopic sleeve gastrectomy. And finally, Antonio Torres, laparoscopic SARI. But the mortality dropped from 10% to less than 0.1%. So I want to tell you what are the things that led to improvement in mortality. One of them is adoption of less risky operations like sleeve gastrectomy. There's literature now to show that sleeve gastrectomy has less complications than gastric bypass. But the 4 main things are that led to the drop in complications and the drop in mortality: the adoption of laparoscopy. That's why training is important, and making sure that you're well trained is important. Laparoscopy improved the safety of surgery. The second is fellowship training. These pictures represent the fellows that have had the privilege of working with for at least a year, some 2 years, at UCSF Fresno, Sheikh Khalifa Medical City, Carolinas Medical Center, Atrium Health in Charlotte, and here at the Brigham in Boston. And fellowship training is an integral component of improvement in bariatric surgery. The third is what I showed you we developed in Abu Dhabi, Center of Excellence designation. And in the US, we have the Metabolic and Bariatric Surgery Accreditation Quality Improvement Program, which was started in 2012. We started our program in Abu Dhabi in 2017. And there's literature to show that if you look at minor complications, there's no difference between accredited and non-accredited center. But if you look at major complications, there's a big difference. And there's been a very interesting concept developed called the failure to rescue concept. And in it, you can show that, for instance, in this study, these are all hospitals. Hospitals in rectangle number 1 or bar number 1 have a 3.5% mortality. and hospitals in bar number 5 has double that mortality. And you would think that their complication rate would be the same, but it's not. All hospitals have the same complication rate, but the hospitals in bar number 1, despite having the same complication rate, have a lower mortality than hospitals in bar number 5. So it seems like what you do after the procedure or the complication happens makes a difference. I want to conclude by talking to you about deliberate practice in bariatric surgery. When you see this picture, you see, people who are known to be what we call, superstars, or you could relate them with being genius. And it's important not to, like Sir Francis Galton ascribe genius and greatness to genetics, because talent is not only based on natural ability, and expertise is not only based on natural ability. And this is what I want to try to convince you in the last part of my presentation. This is Anders Ericsson, one of the premier experts in the science of expertise. This is one of his books, Peak. And I want to talk to you today about the West Berlin violent student study. What they did is they looked at 30 violent students that were matched for sex and age. 10 of the best violinists, 10 of the good violinists, and 10 of the worst. And 10 accomplished violinists in West Berlin. This study was published in 1993. And they went back and looked at them, and they looked at how did they train over time. And they found that you could know that they have different start of their training. And if you ask them to put a diary of a typical week, the best violinists are able to put a diary that matches what they did, because they did it, they remember it. And you could look at the number of hours of weekly practice, and you could, over the time, pick out who were the best violinists. And this was the basic study that showed the 10,000 hour rule that you must have heard of, that it takes 10,000 hours to make an expert. And when data was obtained with interviews, it seems like the more the person practiced, the younger they started to practice, the more they became experts. So there are 5 important principles in deliberate practice. You have to practice outside of your comfort zone. You have to work towards a specific goal. It has to be very focused practice, sometimes uncomfortable. You have to have high quality feedback. And you have to develop a mental model of what you're trying to do. So, this acronym is something I put together to make it easy. The practice has to be focused. Feedback that is high quality, objective. You have to have a coach work with you to create specific tasks in an educational environment to make this deliberate practice. So it's important to get these things together to be able to get deliberate practice. Now, this is important because there are 4 stages of competence, and they happen through practice. And I'm going to give you an example. The 4 stages are unconscious incompetence, conscious incompetence, unconscious competence, and conscious competence. Let me describe them to you. If you ask your little child to drive, they will tell you, I can drive the car. They're incompetent, they can't drive the car, but they're unconscious about not being able to drive. If you ask your 9-year-old or 10-year-old, can you drive the car? They're also incompetent, cannot drive it, but they're very conscious about it. And they will tell you they cannot drive. Your 17-year-old drives the car and they're competent, but they're very conscious about their movements and can get distracted easily, and you can text and drive. So in surgery, we could reach a level of competence where we don't think about what we do, and you could easily do a sleeve in a patient who needs a bypass, or do a right hernia in someone who needs a left hernia. So what does this have to do with surgery or training? This is William Halsted, and surgery training has always been see one, do one, teach one. The reality is you see too many, and you do less, and the environment is not educational. And maybe one of the reasons why we primarily do sleeve gastrectomy in bariatric surgery is because it's difficult to train people to do Roux-en-Y gastric bypass. Roux-en-Y gastric bypass is a more difficult operation. You need to create and close the jejunojejunectomy below the colon. You need to create a small pouch tension-free above the colon. So if you compare sleeve gastrectomy on the right to one anastomosis gastric bypass, to Roux-en-Y gastric bypass, resection only, resection with one anastomosis above the colon, resection with one anastomosis above, one anastomosis below the colon, the learning curve is like using these three skates. And I'm not sure if you know them, but they are in level of difficulty. This ripstick is very difficult to use. And the learning curve is the least with sleeve and the most with Roux-en-Y gastric bypass. So when creating an anastomosis below the colon, you need to have the ports placed in the right location. You need to know intracorporeal suturing. You need to be able to close defects. And you need to work with the person's obesity. Sometimes the heavier the person, the more difficult the case is. And this has been shown in the randomized trial from Sweden that randomized 2,500 patients to closure versus no closure over a year. And over time, the closure group had less bowel obstruction, less internal hernia. But initially, they had more obstructions, probably owing to learning curve. Surgeons who are not used to close defects that started closing defects. So what's the solution? I don't think the solution is robotic surgery. The solution is training. And let me explain to you what I mean. Solution is deliberate practice, focused, deliberate practice. So the way we do this at our training program is we first help people put ports. So the first port we put is the left upper quadrant port at Palmer's point. We place the camera port under direct vision. We place the other ports looking at inside anatomy. Then we teach everyone how to use the needle, and we try to use the tip of the needle in the direction of 9 o'clock versus the tip of the needle in the direction of 7 o'clock to try to explain how to work during surgery to make the feedback high quality. So let's take an example of creating a jejunojejunectomy, something very common, or creating a small bowel anastomosis. So this is a piece of small bowel, this is the mesentery, another piece of small bowel, this is the mesentery. Most surgeons, when they come and create an anastomosis, they put the first suture at the anti-mesenteric border. But this is not what we teach. Why? Because when you do this, the only amount of bowel you could use to create the anastomosis is this part. While if you place the first suture on the inside, then the amount of bowel you have to work with is much bigger. So this is an example of a very important principle that the person has to have in their mind. The second is when you take a stapler and you make an enterotomy, you think the common enterotomy is a circle, but the reality, because your anvil and cartridge are different size, your common enterotomy has a smaller part and a bigger part. So when you close it, you cannot just put sutures equidistantly in a circle and close it. This is not reality. In reality, the way you hold the needle has to change depending on the location, and you have to place wide sutures on one side and narrow on the other side, because if you don't do that, you'll end up with a dog ear. if you place them on the same place. What you do is you place wide sutures on this side, narrow on the other side. And by the time you finish, you would have covered everything. That's another principle you have to teach before the person starts even holding the needle in their hand. And this is a video that shows you what we do. We don't put the first suture at the anti-mesenteric border, but rather very close to the mesentery. Once we do that, other sutures also close to the mesentery, and this allows you to have more bowel to work with. Then we remember which part had the cartridge, which part had the anvil, because the part that had the cartridge is going to create a larger enterotomy. Then it's always important to hold the tissue for yourself and be very slow in your motions while you're suturing. So this is what we try to teach. And as you can see, you know, there's wide sutures on this side, narrow sutures on the other side. And this principle, once you tell someone about it, you let them practice in the lab. We have artificial small bowel lab set up that's inexpensive and that the residents and fellows can use. We use indexed videos to show what the person needs to do. So when you think about bariatric surgery training, you need to think of deliberate practice, which is focused practice, getting feedback and knowing exactly what you're planning to do. So I think the take-home messages today is when opportunities come your way, say yes, keep an open mind, and stay curious. Training in bariatric surgery needs deliberate practice, and always look for collaboration and win-win situations. If you want to go fast, you can go alone, but if you want to go farther, you need to go together. Again, I want to thank Professor Yasser Amir for the kind invitation, and I hope to be able to visit Jamiat Al-Azhar in person next time. It is near and dear to my heart, and I spent 7 beautiful years at your shoes where you are right now. Thank you very much.